Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
First case I ever operated on as a staff was a patient with cholecystitis. By this point, I had done hundreds of cholecystectomies in training. We had done the safety checklist and the anesthetist put the mask on this young lady's face. I watched the white propofol drip into her arm and could hear the steady slowing of her heart rate as she relaxed and drifted off to sleep. As the light faded from her eyes, I was overwhelmed with a feeling of panic. "Wake her up!" I wanted to shout. "There's been a mistake. There is no way I should be operating on this lady by myself." In this episode, we spoke with Doctors McCall and Romy Nitsch about imposterism. Dr. McCall is a minimally invasive gynecology fellow at the University of Ottawa, and Dr. Nitsch is a minimally invasive gynecologist at Queen's University. The two researchers, along with Jessica Pudwell and Jamie Pyper, recently published a study in the Journal of the American College of Surgeons on imposter phenomenon in women surgeons. Their surveys highlights the near universal phenomenon of imposterism among women surgeons, some of the risk factors associated with imposterism, and perhaps some strategies for how we might mitigate it. This is a really important study, and you really need to hear this discussion. Dr. McCall and Dr. Nitsch, thank you so much for joining me on the Cold Steel podcast. It's really an absolute pleasure and a delight to have both of you on the show to discuss a really, really important paper that you have both put out in the Journal of American College of Surgeons on imposter phenomenon. But before we get to that, I'd like to have you tell us, our audience, a little bit about both of yourselves. So maybe starting with Dr. McCall, can you tell us a little bit about where you grew up and where you did your training?
Yeah, so I grew up, originally in Brampton and then in Caledon, Ontario, which is where the area is essentially where my family still lives. I did my undergrad after that in McGill in Montreal and completely fell in love with Montreal. What a beautiful, beautiful city. And then I spent 9 years in Kingston doing my medical school and OB-GYN residency there. And now I'm in Ottawa doing a 2-year minimally invasive gynecologic surgery fellowship. And just a little other positionality, because I feel like that, like the kind of where you come from positionality. So I am a white, queer, cisgendered woman. And, I come from a family who has been able to afford to provide me with resources in my life. And so that gives just a little context for how I approach this work as well.
Dr. Nitsch.
I grew up mainly in Toronto, moved around a little bit. I went to medical school in Ottawa and then to Toronto for my residency. I did a fellowship, AHGL, American Association of Gynecology Laparoscopy Fellowship in Toronto with the people at Sunnybrook. I started my career at Sunnybrook, briefly did an adventure to Australia with my husband while he did his fellowship, back to Sunnybrook, and then moved to Kingston, Ontario, where I currently am a deputy department head in the Department of Obstetrics and Gynecology and a medical director of perioperative services.
Right on. And yes, of course, I have the pleasure of working with Dr. Nitsch on a regular basis, and where she has to try to sort out how I get my urgent colectomies done. So it is
they just keep coming.
I don't know how, but they do. So like I mentioned at the top in the introduction there, we wanted to talk about the work that both of you have been a part of in talking about imposter phenomenon or imposter syndrome. And maybe we could just start, because I certainly learned a little bit from reading the paper about the differences and the nuances between these different terms. Can you talk a little bit about the difference, Jennifer, about the difference between imposter syndrome, imposter phenomenon, etc.? Can you tell us a little bit about the differences and nuances in those terms?
Yeah, absolutely. So I think imposter syndrome is the more colloquial term. It's the term that's come into the popular media. It's been referenced in shows like Big Bang Theory and many other social phenomena. But the original term, as it was coined, was called imposter phenomenon. And it was coined by Dr. Pauline Clance and Dr. Suzanne Imes in the 1980s. And what they actually first looked at was a group of high achieving women, mostly university professors. And that was the first group in whom they recognized imposter phenomenon as they called it at that time. And so the reason that our study particularly uses the phrase imposter phenomenon is because we really leaned on that original theory and some of the scales, like the Clance imposter phenomenon scale. And so we wanted to be really consistent with our language. But in the background materials, we also referenced other studies that use the more contemporary term imposter syndrome. And there's also some thought that in this, for example, this Clance imposter phenomenon scale, There's imposterism or high imposterism and low imposterism. And they also have imposter cutoffs. So I think sometimes when people use imposter syndrome, they might meet people who have high imposterism or who meet that kind of imposterism cutoff, but it's not always clear if that's what they mean or if they mean anywhere on the spectrum of imposter phenomenon.
It's such a neat study, but we're really curious as to what the genesis of it was. Like, how did this kind of cross your radar initially, and then what really prompted you as an authorship group to chase it down and do this?
So I am the faculty supervisor, and Jen was my superstar resident who took the project on. But the project comes from a very personal, emotional place for me. I started my residency in 2000 in Toronto. We were very short. Obstetrics and gynecology was not a very popular specialty at that time. We lost a number of residents. So I operated like crazy during my residency. I felt on top of my game. I did an amazing fellowship with incredible surgeons. I came out well trained. And in the first part of my career, I loved the operating room. Give me a big case, give me a hard case. I'll take anything on. And then I think a series of life events happened. I had my first serious complication. The patient launched a college complaint. I became a mother. I moved to a new city in a new operating room environment where people didn't know me. And all of a sudden, I had this thought, like, can I even do this anymore? Do I know what I'm doing? I continued to operate. I had a very low complication rate. I continued to take on very difficult surgeries. People called me to help them with cases. The nurses in the operating room came to me when they needed surgery. But I really lived with years of doubt whether I was actually capable of operating. I dreaded my OR days, but I would get through them. I could teach. I continued to have a low complication rate. And then all of a sudden I heard this term imposter syndrome, and I started reading about it. And I'm like, oh, maybe there's a label to what I'm experiencing. And then I did a lot of personal work on it, sort of working through my feelings. And then I thought maybe other people are experiencing it. And that's how Jen and I started talking about doing a project about it.
Oh, that's really, really interesting. I asked the question just so not only can you educate us, but I would assume that, others would have the same question. There's clearly nuance and difference between these two concepts, but I would assume there's also a Venn diagram of overlap. And that's the idea between imposterism or imposter syndrome versus sort of humility. Like, I think the portion of what you're talking about that we should all have every day in an operating room. Amir does colorectal operations. I do hepatobiliary and pancreatic operations. And what you're describing, to a large extent, I think helps keep us safe in some ways, as long as it doesn't become, inhibitory or debilitating, which of course is where that syndrome can go. But I was wondering if you guys could talk about the nuanced difference between the two and how you view them.
Do you mean between humility and the syndrome itself?
Yeah, just the idea of feeling like an imposter in that scenario, and then how that leads to the syndrome, and comparatively to straightforward humility with still high function.
Yeah, I mean, I imagine if we almost take a mental health approach, if you're moving into more like an imposter syndrome, you can imagine you might get to a point where you're not able to do your job, or the imposter syndrome is not just those moments leading up to the operating room, but it's starting to sort of infiltrate other aspects of your life. And then it's interesting that you bring up the point of humility, because I've talked to Jen about this. I almost wonder if it's this feeling of self-doubt that actually drives meticulousness in the OR, and then, reduces your complication rate and actually makes you a better surgeon. You're just so terrified that you're going to end up with a complication. I don't know if I could draw a good line where one stops and one ends. I view things very differently right now. I don't have those incredible feelings of self-doubt, but I think you're right. I like that. I like the concept of humility, and I think it maybe reframes it a little bit better than the syndrome concept.
Yeah, and one thing, maybe I'll just take a step back and actually define imposterism, because I think we got a little bit away from doing that at the beginning of the podcast. So imposter phenomenon is the profound belief of being incompetent despite objective evidence to the contrary, and the fear that others will discover this hidden incompetence. It goes beyond self-doubt, as we've also phrased a lot of the questions in the study, into that real deep-seated fear or belief of incompetence. Again, despite, as Dr. Nitsch even said about herself, like very low complication rate, extremely highly qualified surgeon, but it's still that experience of feeling incompetent and being afraid.
Almost like a fraud, right? Almost like the fraud concept.
Yeah. A lot of the things that Dr. Nitsch just described were also things we heard from participants in our study. And so the paper in the American College of Surgeons is only about our quantitative data, which was obviously all numerical. But in this study, which was multiphasic, we also had qualitative data from the survey, which is going to be hopefully our next publication. And then we also did a series of interviews. And in both of those, which is unpublished data, I can reiterate some of the same things that people said. The spectrum, people said, I think that some element of my self-doubt is healthy. I think that some element of doubting myself is being a good surgeon and is making me better and careful and cautious. But then also people talked about the way that can impact so many aspects of their life, or even, as you said, Dr. Nitsch, take away the enjoyment of operating. And I think it's one thing to feel cautious and try to provide the best care for patients. And it's another thing entirely to really doubt that you can do it at all, or that you should be doing it, and to also feel that creep into other aspects of your life. And we did see in the study that it impacts people in their work, in their personal life. It really starts to seep outside of the caution in the OR.
Dr. McCall, can you talk to us a little bit about the methods for this study? You talked a little bit about the survey scales that you use to actually assess imposterism. But can you talk us a little bit briefly about the methodology for the paper and some of the top level highlights of the results from the paper? And we'll then do a deep dive into some of the things that we found really interesting.
Yeah. So very briefly, we started with a survey. And so our target audience was any woman surgeon in Canada who either had ever trained or practiced in Canada or was currently practicing. So it included people, we were trying to capture people not only who were currently practicing, but we were also worried about this group of people who might have left practice due to imposter phenomenon. So we tried to capture anyone who may have retired or done some of their training in Canada. And then we sent out a survey online, and we targeted it mostly through social media. We did targeted distribution through various hospital and university groups as well. And we actually got over 300 respondents, 387 respondents, and that's the complete data set. So we did have some, unfortunately, incomplete data sets, which obviously we had more respondents than that. And we actually estimated that was between 30 and 60% of the women surgeons in Canada. So we were quite happy with that response rate for a survey, which, as you all know, is usually closer to 20%. In this survey, we asked for some demographic information. We did the Clance Imposter Phenomenon Scale, which is a 20-item validated questionnaire looking at imposter phenomenon. And that was if you had to answer at least 2 demographic questions, your age and what surgery you do, and the Clance Imposter Phenomenon Scale to be included in the data set. And then we also asked some self-designed questions about imposter phenomenon, such as we had a lot of hypotheses about how this might impact female surgeons in their work or women surgeons in their work. So things like, do you ask for a experienced assistant more commonly, things like that. And we also had some open-ended questions about the impact of imposter phenomenon or the experience of it. After that, from that study, we then recruited 20 additional participants for interviews, both in English and French, and did approximately hour-long interviews with 20 participants in greater depth. But this particular publication only focuses on that quantitative data. The main finding, I'll say, being that 99.7% have ever experienced imposter phenomenon. So it's essentially ubiquitous among women surgeons to have this experience of imposter phenomenon and self-doubt.
Yeah, it's a crazy statistic. We should just get this out of the way right off the hop. If you chose not to survey male surgeons, can you talk a little bit about that decision?
Yeah, that's one of the most common questions we get, definitely, about the study. And so there is a lot of feminist theory that essentially says we don't have to compare women to men for findings about women to be valid, and that the experiences of women are unique. And it's not to say that men don't experience self-doubt, that men don't experience imposter phenomenon. And there are many studies looking at general surgeons, for example. There's a group of, I think it's Leach, that wrote the paper on general surgeons and general surgery residents in particular. It captures men and women. And it's not even completely clear whether the experience of imposter phenomenon is higher among women. Some studies say yes, some studies say it's equivocal. I haven't seen a study that ever said it's higher in men, but we did feel again that the experience of women is unique, not only in the way that sexism is experienced in the OR, but overall the socialization of women and how even coming into medicine, and then as well as those additional sexist factors and that we can experience, especially in the operating room environment, we thought that might be a unique environment. So we were really more interested in the experience of women rather than saying this is how it compares to the experience of men.
That's a valuable and important thing for people to understand. And I appreciated actually the stance that you took on this paper. Okay, so 98%, everybody, all the female surgeons who responded to this study said that they had imposter syndrome. Dr. Nitsch, why is this such a ubiquitous phenomenon in women surgeons?
I don't know if we really know. I don't think that our study necessarily could get to the bottom of that. I can make some guesses. I still think there's some gender bias in medicine. Things are changing, but there can still be some lack of representation and mentorship for women in surgery, not so much in a field like OBGYN, where it is now becoming more female dominated, but certainly in some of the other surgical specialties, we haven't caught up. There can be some high expectations and pressures to perform exceptionally well in male dominated environments and specialties. I think there's balancing work and family responsibilities, can lead to feelings of guilt or self-doubt, still not being able to, get all the things done as you want them to be done. Perfectionism, fear of failure. I don't know how common those things are in our male surgeons, but I certainly know that they are common amongst the women that I work with.
Yeah, it's a profound, finding. If that's the only thing people took away from the paper and this study, I think in one sense, it's kind of reassuring, or it might be reassuring to other women surgeons to know that they are amongst everyone else and feeling the same way. And I don't know if that lessens it or makes it worse. I don't know, but certainly I think it's reassuring even to me as a male surgeon to know that so many people feel like this as well. There was a small subset of surgeons who did not really seem to have had imposter phenomenon throughout their career. I mean, again, we're probably pushing you both to speculate, but what do you think distinguished those few surgeons who really didn't feel like they had experienced that, Dr. McCall?
Yeah, they didn't give us a lot of information in the free text. Some people just said, why are you even asking this question?
Some people were really mad at us, actually. Do you remember, Jen? Some people were quite angry at us for doing this study.
It was a minority, like a small number of people.
Yeah. Angry, why?
Well, I think people just felt frustrated. Like, why are you sort of accusing women of having self-doubt? Recent publications and evidence suggest that women have better outcomes in the OR. They also save the healthcare system money. So, why do we need to suggest that now there's a self-doubt problem? And I think that's where those feelings came from. As Jen said, though, it was a very small group of people.
We have to acknowledge that there's certainly some response bias as a limitation of our study, that although we didn't put the title self-doubt or imposter phenomenon anywhere in our study advertisements very purposefully, hoping to reduce our response bias, but we certainly can acknowledge that that might be a factor in the great percentage that we saw, although again, our response rate was very high. But certainly a few people did respond to the study and say, like, why are you even asking this question? Like, why are you asking me tons of questions about self-doubt? Why would this be an issue? I don't have a problem with that. So some extremely confident surgeons, we're so happy for them, opted ultimately to not focus on that in the interviews and to instead focus on understanding the experience, although it is an interesting one. And if I could step back to just to your last question about, well, first of all, you made a comment about how so many women knowing about this might feel, just happier or better to know it. We did see, again, in our further research that it is a mitigating factor to speak about it with peers and to know that you're not alone in this experience, certainly mitigating. And I would say that the biggest causative factor that came out of our more in-depth study of the qualitative surveys and the interviews was that the environment is the factor. Surgical environment is the cause of self-doubt. And so I think that speaks to those people who felt so angry with us for perhaps implying that female surgeons are imposters or less worthy of being surgeons. It's not that at all. It's the surgical environment and also the learning environment. We only interviewed and surveyed staff surgeons, not trainees. And many people spoke about their experience in training as being really formative in this experience. And so it's both the surgical operating and learning environment that are huge contributors to the development and persistence of imposter phenomenon more than anything that's internal to the person themselves.
So clearly this is having really big effects. And it was kind of sobering to read in the paper about what an impact imposter phenomenon had on folks on their careers. Like there was the impact it had on research, and that the folks didn't want to do research anymore and things like that. But like the part that really killed me was the 3% who gave up their career in the operating room. Like that, what a profound loss for someone who spent all these years training to be surgeons and to work in the operating room, and to give that up completely is really profound, and kind of goes to what you were talking about at the beginning of the show, Dr. Nitsch, about the difference about humility versus this imposter phenomenon. Like this is really having an impact on these folks' career. Can you talk a little bit about what you found in the study on the impact that imposter phenomenon is having on women's surgeons' careers?
There are a small percentage of people that leave. There's a small percentage of people that will shift their career focus. So they'll move out of the operating room and pick other things. But there's something that Jen said that struck with me. It's the lack of enjoyment of the day. And so you're supposed to want to go to work. You're supposed to be proud of what you do, and you're supposed to feel, satisfied and that you're contributing. And if you're having this day of dread, that's really going to impact you. And I think, the impact is going to be in other aspects of your job when you're seeing patients in clinic. It might be in relationships, and you certainly can take it home if you're worried or stressed. So I think, that's sort of the area where it can start to become a little bit more pervasive.
Maybe the only thing I'd really emphasize about the sadness of the situation is that the question was specifically, have you given up operating due to self-doubt? And so I don't want there to be any doubt on the part of anyone listening that, these 3% of people will give up their careers because of their surgical careers because of X, Y, Z, other reasons. No, the question was specific. Did you give up operating due to self-doubt? And that does have a big impact on the healthcare system. I think that was one of the other things we were interested in starting the study is what is the attrition? We know there's an increased attrition of women surgeons compared to men surgeons. And what are some of the contributing factors to that attrition? Now, if we lose 3% of female surgeons, I don't know how much that contributes to the overall attrition. But again, I think when it comes back to that root cause of the environmental factors, I'm sure that has a lot to do with the attrition of women surgeons, and fixing that environment is how we're going to improve the healthcare system and make better use of that big investment in resource, as you said, in training from a personal level as well as a systemic level.
Yeah, I think it's very important to say that it's not just that people are not operating more, but that really they're not fulfilling what they could be simply because of this self-doubt, or not simply because, but because of this self-doubt or imposterism. We talked a little bit, and you mentioned a little bit about perhaps some of the strategies to help mitigate imposterism. And I know this wasn't the thrust of the paper. This paper was describing sort of the incidence of it, but from the work that you've done and perhaps some of the background literature that you've dug into, what do you think, Dr. McCall, are some strategies that we can help mitigate this really, obviously devastating process or syndrome?
Mm-hmm. Peer support has certainly come out as a really important aspect. And I think that a lot of that right now exists behind closed doors or over a cup of coffee or with a colleague to whom you feel close. And I think there's a lot of opportunity for more structured peer support. But again, that also comes in, I'm going to be a broken record, in the form of changing the environment. So a lot of people, again, later on in the study spoke about how, I won't use the very inappropriate colloquial term, but when you're at a round and someone is asking you repeated questions over and over and over, and essentially aiming to humiliate you, aiming to find the knowledge gap and humiliate you, or when people have to bring a complication to case rounds that they haven't even maybe processed yet, in their own way, they're having an emotional experience about, and then they're asked to bring this and present it to a case rounds that is then very judgmental and very harsh. That is an environment that really exacerbates this experience. And so when we change that environment, we make it safe to bring complications when the surgeon is ready to offer to bring it instead of being told to bring that complication. It's so important that we reflect on complications, obviously, and what can be done differently, but the manner in which we do that is different. And some surgeons even said, after the case rounds, people would come up to me and say, "Oh, I'm so sorry that happened to you. I've had the same experience." But when we're sitting in a room full of people, they're drilling me. And how is that collegial when we can all relate to having that experience? So that's changing the environment, obviously, is one thing. Peer support, again, formalized perhaps. Interestingly, we did not see that people who had a mentor had less IP. That came out of the study as well, and that is in the JACS publication. And further research on this shows that that's because mentorship means different things to different people. And so having a high quality mentor was a very different experience from someone who would say, "Well, I guess I have a mentor. I have someone who's, led me through my career or been my program director, but that person was really unsupportive. I couldn't talk to them about my failures. I felt like they were judging me. I felt like if I talked to them about my complications, it would impact my career progression." So I think if we talk about high quality mentorship, the potential is there. Finally, I think that we've also talked about how could the healthcare system do this? And again, coming to that assistance level or having a colleague operating with you at different points in your career, especially around transitions. The first 5 years of practice were shown to be a particularly difficult time for surgeons, a very big peak of the experience of imposter phenomenon. So how could we do better from a structural perspective to support surgeons in their first 5 year of practice? And frankly, how could that also look differently from a billing perspective, whether that's just the fact that, assisting obviously can be really, at least in Ontario, can be really lucrative. And so maybe that's something that just needs to be considered, but how can we make it such that it's financially feasible for junior surgeons, graduate surgeons, but junior surgeons to have that mentorship in the OR when they need it, or have someone who's there and available to assist them if needed. So I think those are all kind of structural ways that we could improve this experience.
I also like the idea of like mentor as a coach. The operating room environment is intense. It can become critical. You have to navigate learners. And so, I like the idea of mentor as coach. How do you help someone in their first few years of practice build confidence and be realistic about their goals and develop strategies for coping with complications? These are all really important things. And I like the fact that Jen identified that there are other times where transitions are important. You move to a new city. Well, maybe you need someone to scrub in with you for the first little while to get comfortable in that environment, to have other people get comfortable with you. And what about when you come back from maternity leave? Some of us don't feel really good when we come back from maternity leave. Maybe you need a buddy to scrub in with you for the first little while that you're back. And you probably can get through the surgery being really tired, but maybe it's just nice to have somebody else there by your side getting through the surgery together. What we do is really difficult. And so it's very important to feel well supported.
I was going to ask you specifically about how we can support folks who are coming back from maternity leave, because this came up in the paper as well too. Women surgeons that had children under the age of 6 were more likely to have imposterism. Like, are there any besides having another colleague in the OR with you, what other things can we do to help surgeons who are coming back from maternity leave or have young children?
You're closer to it, Jen, than I am. What would have been helpful for you? Your staff sending you home to breastfeed?
If you can't hear the snaps, Dr. Nitsch sent me home early on a shift to breastfeed, and that honestly, it made me cry. It was amazing. Coming back at 5.5 months after having a baby is really difficult. I think one of the things I really want to highlight is you quoted that stat perfectly, Amir, that we did see an increase in women surgeons with children under the age of 6. But I want to highlight that in the study overall, parents compared to non-parents did not have a different degree of imposterism. And I think as a parent, that feels really important to say because I think that there is some prejudice against mothers, particularly, right? There's actually this is a well-developed social phenomenon. There is a motherhood tax and there's a fatherhood tax credit basically in the workplace. So imposter phenomenon did not disproportionately affect mothers or parents, but it did affect women with children under the age of 6. And so some of the things that we came out in the data, I'll speak to my own personal experience too, but some of the things that came out in the data is again, I'm sorry to harp, but it was the environment that people said. I came back from mat leave and people treated me differently. People acted like I couldn't take complicated cases. They would send me less complicated referrals. I wasn't given the same responsibilities within the department. Sometimes that was when they came back from leave, but sometimes that's even in pregnancy. These roles are being withheld from people, even from the time that they declare they're pregnant, which is why a lot of people do choose to conceal their pregnancies for as long as possible in the surgical environment. And that's even more striking in obstetrics, frankly, but it's still true. So I honestly feel really lucky that I came back as a trainee, which I think could be a very different experience to coming back as a staff member, because I got to come back to a supportive environment where I had that coach, I had that opportunity, and I got to go back to the OR 3 to 5 days a week. So I honestly think that re-immersion intensive is a great way to get back into operating and rebuild your confidence. And obviously in the era of very limited OR resources, that's difficult, but I can't imagine having come back to a situation where I was operating once or twice a month after having not operated for 5 or 6 months. I think honestly, it pushes women to come back from leave sooner than they want to because they're afraid of losing those skills and going for such a long period of time. But if somehow those ORs that are lost could be regained in a short period of time after, and then having a surgical coach with you that first period of time, I think that experience for me as a senior resident left me feeling really, really good within a few months, like almost immediately upon being back, actually.
We've been exploring this topic in a variety of different ways. It seems like, maybe we should all be having a coach, whatever stage of the game we are. We had a guest on a couple episodes ago who has been doing coaching for bile duct injuries. It's interesting, like many of the same kind of issues would come up with folks who have had a major complication and needing that coach to kind of help them from that. So maybe we just need to have one, period, like someone that we check in. I know this paper just came out recently. I'm curious if either of you have gotten feedback from readers or from colleagues about the study and what folks have said to you about the study, because it's a provocative study. And I think people might have, you already mentioned that some people got really angry for even asking the question. I'm curious what kind of feedback you've gotten on the paper.
We got a lot of thank yous for asking the question and taking the time to really look into it. I think most of our feedback has been positive. And just like you're asking the questions, what can we do? I think it really highlighted the fact that we need to do something. And for me personally, I'm on the lookout for people now amongst me that might be, having a hard time in the OR, that might be having some anxiety, that might be having some self-doubt, and just really from a personal level, there to offer support and be around. Jen, I don't know what you would say, but I think overall people really were positive and quite grateful that we did it.
Yeah, absolutely. Since the paper's come out, I've also had people reach out to me for the full text copy of the article internationally. I had a surgeon from France, for example, reach out and ask for a full text copy of the paper. So people are definitely interested in listening. And, this was an experience of Canadian physicians, but it got published in an American journal. This is an international issue for surgeons. I would say most of the feedback I've received is I've presented this at several conferences and definitely have received a lot of positive feedback, both from audience members who have experienced it, a lot from learners who are very interested in how this plays out and what they can do to protect themselves moving forward. We were fortunate to win some awards presenting this work at the conferences, and always a lot more questions, always where do we go next and how do we fix it? And it's not an easy fix. So we'll have to definitely move forward. And again, supporting people after complications, that's another thing. Complications was a huge trigger in the subsequent phases of the study. So definitely supporting people around complications, and people definitely come up and say, oh, after this happened. So I would say overall, actually extremely positive reception to the data.
So what is next for Dr. McCall and Dr. Nitsch? Where do you go? I know you're going to publish, sounds like, the qualitative side of this study, but what's next for the hunt for the elimination of imposter syndrome?
Well, now that we've had this podcast, I'm all inspired to revamp it and continue on.
Yeah. Yeah, we need that to get through the last few manuscripts. We'll definitely publish that. We're going to do the qualitative data. We're also, this study is actually designed to be a mixed method study. And we have a mixed methodology expert, Dr. Jamie Pyper, who's been really phenomenal in guiding us through the methodology. So not only will we individually publish the quantitative and qualitative data, but then we hope to do a triangulation and depth of analysis, using both the quantitative and the qualitative, and how do they kind of speak to each other. So that's going to come. But I think on a personal level, this has really impacted the way that I try and speak about things like, complications. And as a trainee, I know that looks a lot different than as a staff person. But, in the resident room in Kingston, I'd come in at the end of the day and be like, and I don't mean this to sound, for anyone who's non-medical out there, I hope that this won't sound too brazen, but like, shit, I cut the bladder today, or shit, I perforated the uterus today. And just coming in to say, this is what happened. And also I have to go home tonight and, and go breastfeed my child and not think about this all night, and how am I going to come in here, be really frank and honest about the things that I did wrong today, process them, and then leave them at work. And I was always surprised how many times I'd come into the resident room and say that. And someone would go, oh my God, that happened to me last week or last month. And it seems like sometimes people have talked about it and sometimes they haven't. So on a personal level, I've definitely tried to be really open about all my mistakes, for better or worse.
Well, we can't thank you both enough for chatting with us today about your groundbreaking manuscript. We really appreciate your work, and we look forward to what you certainly will do next, and your time today. One of the things we ask each of our guests, as you may know, in closing, is if you were to go back at an earlier stage in your career, whether it was maybe beginning your career as a junior faculty or maybe beginning your voyage as a junior resident, what advice would you have given yourself?
My biggest advice is be kind to yourself and be kind to those people around you. We have the best career you could ever have, but it's really hard. And so, it's just reminding yourself at every step of the way to be kind to yourself and to others. I wouldn't change anything else in my career trajectory. It brought me to where I am, but maybe just, reframing that from the beginning, I think would have gone a long way.
My main experience of imposter was definitely as an R1 on obstetrics. And I definitely look back to that. It's a huge transition from being a medical student to a resident. And I think there's a lot of imposters and that can surround that transition. So I definitely try and share that experience. Again, I try and share it from my own perspective. Well, this is what happened to me with the junior learners. And I actually look back to a teacher, Michelle, who I'm so sorry, I forget her last name right now. Michelle, if you're listening to this podcast, you know who you are. She's a geriatrician at Queen's. And she gave us basically a small talk about imposters in like the first week of medical school. Once I looked back and went, oh my God, that's what she was talking about. It was imposter phenomenon. The more we talk about it, the more we help other people who are having that experience. So I think I would just go back and tell myself, like, this is what's going to happen and it's okay. And other people go through it too. So thanks for the question.
Fantastic. Thank you both.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.